Hello, friends. We're going to go live in a minute. Let me just share the link with Hello, friends. Some of the groups. We're going to go live in a minute. Let me just share the link with some of the groups. Okay, let me share my screen and not that. Okay, so today's session, and before actually I start my today's session, we will actually go through some anatomy part which I wanted to share last time. So we are going to actually talk about the lumbar plexus, how we can actually draw the lumbar plexus, and the easy way to actually draw that. Okay, so let's start with that. So the lumbar plexus takes origin from L2, L3, L4. L4, L5 forms part of the lumbosacral trunk. And then we can divide these into ventral divisions and dorsal divisions. And the femoral nerve takes origin from the L2, L3, L4 dorsal division. L1 also participates in the lumbar plexus and gives rise to inguinal iliohypogastric nerve. Iliohypogastric nerves gets a branch from T12 as well. And L1, L2 also forms the genitofemoral nerve, which obviously divides into the genital branch and the femoral branch. The L2, L3, L4 are the ventral divisions form. That's wrong. It's actually the obturator. Ventral division forms the obturator, not the femoral. The dorsal division actually forms the femoral nerve, not the ventral division. So that's actually wrongly labeled. L2, L3 dorsal division also form the little cutaneous femoral nerve. So that should be little cutaneous and the femoral, not the obturator. So that's actually, I think, wrong in this diagram. So drawing the lumbar plexus itself with the, showing the actual anatomy, the gross anatomy. So there's this T12, and we go L1, L2, transverse process, and the bodies of the vertebrae. And that's L3. And similarly, you can actually draw the other ones as well, L4. So that's very easy. It's not very difficult to actually draw these diagrams. So now what we're going to do is with a different color pen, we're actually going to draw the iliopsoas muscle, which takes origin from T12, L1, L2, L3, L4. So that's our psoas muscle. And we know that the nerves lie in the psoas compartment. Okay, they take origin from the L1, L2, L3, L4. Right? So that's our the IM. So that's the anterior superior leg spine, and we got the pubic tubercle, and joining these two is the your inguinal ligament. So that will be our inguinal ligament. Okay, so that's the inguinal ligament. So you need to keep labeling the, yeah. So that's it, and then that's the iliacus muscle. So it's iliopsoas, isn't it? That iliopsoas takes, tend to insert into the less middle side of the femur into the lesser trochanter. Okay. And coming on the lateral side is our femoral nerve. Okay, it goes behind the inguinal ligament. Okay, and on the medial side is the obturator nerve, lying on the obturator. Okay, and then you have the other nerves as well. So that's the obturator on the medial side, femoral on the lateral side. Okay. And then we have our lateral cutaneous femoral nerve, or the lateral cutaneous nerve of the thigh. Okay, so that comes out of sort of midway onto the psoas sheath. It pierces psoas sheath, comes out of that. Okay, lies on the side. Okay. Okay, going in a minute, actually go and show. So that was our lumbar plexus and the diagrams. We can there's another simple diagram which I'll actually had shown in the previous lecture, where you can actually draw a sort of a cross section and explain our how we block the femoral nerve, how we do the facial iliac block. So that is another one which we can actually draw. I'll post that sometimes on the group. So coming to today's lecture, we have 6 lectures today. So the first one is on ophthalmology, so that's about oculocardiac reflex. Second one is in obstetrics, thrombocytopenia. Third one is cardiac on pacemakers. Fourth one is on hemofiltration, so intensive care. And then we have one on cardiopulmonary bypass, that's again cardiac. And we have the basic anatomy of a caudal block. Okay. So coming to the first question, the question is, what is oculocardiac reflex? What is the mechanism and presentation of reflex during the strabismus surgery? And what are the management approaches to prevent or treat the oculocardiac reflex? So this is not a very difficult question. This is actually pretty easy question. So this reflex is also known as Aschner phenomena, Aschner reflex, or Aschner Dagnini reflex. It's a trigeminal vagal reflex response. So it originates in the trigeminal area, and the response is effected through the vagal nerve. And it is elicited by pain, pressure, manipulation of the eyeball. And hence, it is quite common during the surgery on the eyeball, okay, and especially the strabismus surgery. And it manifests as cardiac arrhythmias and hypotension. Okay. You can also draw a simple diagram of the eyeball and the muscles. So the efferents go through the long and short ciliary nerves, pass through the ciliary ganglia, via the ophthalmic division of the fifth cranial nerve. And the integration occurs in the medulla and the floor of the fourth ventricle. And the efferent arises from the nucleus tractus solitarius, okay, which is obviously part of the fifth cranial nerve, okay, and in the medulla. So, and then through the vagus nerve, it actually reaches the heart. So that's in diagrammatic form. You will also need to actually write. So, like I said, afferents come through the long and short ciliary nerve, pass through the ciliary ganglia along the ophthalmic division of trigeminal nerve, and then terminate in the main trigeminal sensory nucleus in the floor of the fourth ventricle. So the integration occurs in the medulla, and the efferents then pass. They start in the nucleus tractus solitarius or the vagal cardiac depressor nerve, and then pass on to the heart, and where they actually affect the negative inotropic and condension effect, and that's why you get the bradycardia and other, you know, arrhythmias and hypertension. So the mechanism and presentation, I said this is very common during strabismus surgery in children. The incidence can be as high as 32 to 90%. And the presentation is usually bradycardia, sorry for the spelling mistake there, and hypotension, but it can even lead to asystolic arrest. And this is seen in 1 in 2,200 cases. And the factors that predispose to the arrhythmias and hypertension or the increase in incidence of the oculocardiac reflex is hypoventilation with hypercarbia. So increasing PCO2 is important. What about the management? Obviously, the first thing you will likely ask is the surgeon to stop manipulating, stop putting pressure on the eye. Okay. Sometimes they, when surgery is actually going on the head end and the head is hidden and like they're doing surgery on the mouth or third, sometimes even the surgeon's, assistant pressing on the eyeball can lead to this reflex. So you need to protect the eye from the pressure effect. So the first thing you're going to ask them to relieve the pressure or stop operating. You can actually give atropine and glycopyrrolate. Some people tend to give prophylactically, or others just wait and see what happens. And despite of this, if it still occurs, then you make sure that the surgeon is told to be gentle with manipulation. From our side, we need to make sure that the patient is being ventilated, there is adequately ventilated, that the CO2 levels are normal. And if despite all these measures, if there is still, the surgeon is still very gentle and still happening, you can then ask to actually surgeon to inject some local anesthetic into the muscle. So this will actually block the afferent fibers. Okay. And if obviously it is a cardiac arrest happens, then you will need to start CPR. So you start cardiac compressions. So management depends on the presentation. So some things can be done prophylactically, others need to actually manage it as we go. Okay. So that was our first question of the day. The second question of the day are, you are called to see a Pacemaker with preeclampsia in the first stage of labor, and she's requesting an epidural. And then you look at our platelet counts when you're doing the examination and investigations. You look at, and the platelet counts are 60,000, but that was last night. So what are your differential diagnosis? And outline how and why you would proceed. Okay. Or would you proceed? So during the pregnancy, the platelet counts do go down by 20%. And it is seen that almost 90% of the patients actually have platelet counts of 150,000. 6% have counts between 125 to 150. 3% have 100 to 125 or 124,000. and around 0.6% have from 80,000 to 90,000, 99,000, 100,000. And only 1%, oh sorry, 0.1% has from 60 to 80,000. So patients with counts of less than 60,000 is very rare. Also, you need to be aware that thrombocytopenia, whether it is static or dynamic. So if you look at how platelet counts over the last few times, and you'll see and look at whether they have been static or there has been a dynamic drop or this is a one-off reading. That is actually important. Okay. So moderate to severe thrombocytopenia is considered as counts less than 100,000. And the commonest differential diagnosis in this case is going to be gestational thrombocytopenia, which is present in 59% of the patients. But like we said, that in gestational thrombocytopenia, the counts do not actually go down to such low levels. Okay, so you have to start thinking of other causes. Okay, things like preeclampsia with severe features of HELLP syndrome, which actually is a differential diagnosis. This is seen in 22% of patients. HELLP obviously is an acronym for hemolysis, elevated liver function tests, and low platelets. Could it be immune thrombocytopenia? Okay, so ITP that is seen in 11% of patients. And then there are other causes. Okay, so other causes are seen in 8% of patients. So causes like antiphospholipid syndrome, DIC, dilution thrombocytopenia, myeloproliferative neoplasms, drug-induced thrombocytopenia, infected causes like HIV, hepatitis, inherited causes like von Willebrand disease type 2. Okay, these can also present with thrombocytopenia. So we need to be aware of these causes. And like I said, as platelet counts of 60,000 are at least very rarely seen. So you need to actually go into the history. So you need to look at the past medical, surgical, anesthetic history as you would do in any patient. You need to look at the course of the pregnancy so far, and you need to look for any presence or absence of complications. You need to ask the patients if there is any signs of infection, if there has been history of fever with chills and rigors. You need to look at if the patient has been introduced to any new medication in the past 3 weeks, or is the patient taking any occasional medications which may cause thrombocytopenia. A family history or personal history of excessive bleeding, bruising, complication, pregnancy-associated complication, or if there are any known thrombotic microangiopathic syndromes present, history of that present. Okay, this is important. You need to look at the history of systemic lupus erythematosus, SLE, or other autoimmune disorders. Is there a history of liver disease? And we need to look at the timing of drop in platelets. Which trimester did it happen? Has it been throughout the pregnancy, or it has only happened in the later part of the pregnancy where there is maximum dilution of the volume occurs? And if there is presence of anemia, okay, that is more than expected for the stage of pregnancy. Again, dilution and anemia occurs, but is this more than what is expected? And we also need to look at the abnormalities of peripheral blood smear. Okay, look at for abnormal white cells or nucleated red blood cells. So a peripheral smear will be very useful in this patient. So you do not just proceed with someone with a 60,000, a count of 60,000. It is actually very uncommon to have patients with such low counts. You obviously will also look at the patient's vitals like heart rate, blood pressures, SpO2. You would examine the skin for purpura or bruising or petechiae. And you will also ensure there's no clinical evidence of bleeding or excessive bleeding or as patient oozing from the venous side or other procedural areas where you look at areas from where they have taken blood. Is she clotting? Okay. You would also do a systemic examination looking at the respiratory system, cardiovascular system, CNS, GIT, etc. Okay. In the investigations, you will look for the full blood count, look at the platelet counts again, like I said. You might want to see bleeding time, not done nowadays that commonly. Okay. Clotting screen, you look at APTT, PT, and fibrinogen. If you have facility for thromboelastogram, that's nothing like it. Okay, the maximum amplitude should be more than 53 millimeters. Okay. So if that is there, then the platelet count from 54 less than 50 to 75,000 are considered to be okay. If you have access to a platelet function analyzer, okay, so there are two types. You have the CEPI or CADP. Okay, so this is the collagen with 150 micrometer aperture, and then you look for the closing time for the aperture. So, these are two types of platelet function analyzers. Okay, you look at the urea and creatinine, and you look at liver function test, and we will come to that. Why we need to look at that? You need to look at the urine analysis. So this is the analysis of, so if the patient has got isolated thrombocytopenia, okay, then you start looking for severe ITP or drug-induced ITP. If the patient has history of fever and chills, then you start looking for infection signs of DIC. If the patient has severe hypertension on examination, then think of preeclampsia with severe clinical features like HELP syndrome, or look for possible thrombotic microangiopathy. If the patient is hypotensive, is there been excessive bleeding or DIC? Are there any signs of neurological findings? Then look for possible central venous system bleeding, preeclampsia, DIC, or TTP. If the patient has got bloody diarrhea, then look for Shiga toxin mediated hemolytic uremic syndrome. This is very rare, STHUS, and possible thrombotic microangiopathy. If there is hemolytic anemia, you will see drop in hemoglobin. There'll be rise in LDH and bilirubin. Okay. These could be signs of preeclampsia with severe clinical features, DIC, or TTP. Yeah. On the blood smear, if you see cystocytes on the blood smear, then you start thinking of thrombotic thrombocytopenia, or look for the complement-related thrombotic microangiopathy, or CTMA. This could also be seen in preeclampsia with severe clinical features or HELP syndrome, possibly DIC. If there is leukopenia or leukocytosis, again, look for signs of infection and DIC. If you see prolonged PT and APTT with low fibrinogen, again, look for signs of DIC or severe liver disease. If there is rapidly increased creatinine, so you look at the trend for creatinine, then you think of the complement-associated thrombotic macroangiopathy, or the STHUS, which I actually talked, sugar, okay, toxin-related, okay, or DIC, okay. If there is elevated liver functions, then you think of preeclampsia with severe clinical features, HELP syndrome, or AFLP, that is acute fatty liver pregnancy, infection, example, viral illnesses can also cause that. If the patient has low blood sugar, then you start thinking of acute fatty liver pregnancy. And if on urinalysis they actually have proteinuria, then you think of preeclampsia or HELP syndrome. So this is the overall analysis of the various findings you can actually look at. Like I've said, if you actually got thromboelastogram, nothing like it, you can do analysis of that. I look for if the MA is, the maximum amplitude is actually more than 53. So this is a thromboelastogram, R value, your K value, the angle, okay, R K value, the maximum amplitude. So these are various values, and we will actually take a class on that sometime. So how do you manage it? First of all, you need to actually decide, is epidural really necessary in this case? And then you have to look at and rather rule out the causes for the thrombocytopenia. You don't want to actually get into a mess where there are other complications are present. You need to actually inform the patient of the potential risks and benefits. There is a 1 in 150,000 to 250,000 chances of patient developing epidural hematoma in this case, even though we can actually do spinal in patients with 62 to 75,000, but is it really necessary? And if there is a strong indication, then you might want to consider platelet transfusion, for which you will need to consult the hematologist and also discuss the case with the obstetrician. And if it's just purely for analgesia purposes, you have to think, well, we could actually think of other methods of analgesia. Could this possible patient have a PCA? Or the patient could actually use Antonox and use complementary therapies. So that we have to start looking at other alternatives. But that does not mean we would stop thinking of this, because if patients end up for cesarean section, we would still need some help. So it's important that the hematologists are involved with this case, and they would investigate further, take a peripheral smear, go through the history, and find out what the cause for this severe thrombocytopenia in this case is. So for epidural anesthesia in such cases, general rule is epidural is normally thought safe if the platelet counts are more than 50,000 to 80,000, but their counts are stable. So it's important to look at the dynamic range of platelets. You don't actually look at a single reading and say that. And the platelet function is normal. That means that the platelets which are there are of good quality. It's important to rule out that the patient is not on any antiplatelets or anticoagulant drugs. And there are no other acquired inherited coagulation disorders. So count, function, and quality are important part of the epidural anesthesia. And count is just one of the numbers you are actually looking at. Coming to the third question. Third question is about a patient presenting for total hip replacements. It tells you that he has a pacemaker. So what further information do you require? And how will this influence your anesthetic management? So the first thing you need to know is, what is the indication? Why did the patient actually end up with a pacemaker? So there are a number of indications, and it could just be symptomatic sinus bradycardia. The patient has complete heart block. It could be because the patient has sinus node disease or sick sinus syndrome. It could be symptomatic AV node disease like bifascicular and trifascicular block. It could be tachyarrhythmias. HOCM, dilated cardiomyopathy, long QT syndromes are other important ones. And more recently, the pacemakers have been used for heart failure, for remodeling. It's been used in sleep disorder breathing. They've been used post-MI, and they've been used in patients with poor LV function. So it's important to know what kind of pacemaker it is. Obviously, if the patient has got a pacemaker, temporary pacemaker, you will see the unit outside, but this patient probably had got a permanent pacemaker. And again, if it's a permanent or pacemaker, does this patient have the card, which will tell us what kind of pacemaker it is. So the pacemakers are classified according to the NASPE, that is the North American Society of Pacing and Electrophysiology, and British Pacing and Electrophysiology Group, or BPEG. So it will tell you when the pacemaker was inserted, what kind it is, when what is all last tested. So you need to actually ask the patient if they got the pacemaker card. Then you will need to know, is it functioning well, when it was cited, when was it last serviced, or when it was last tested. A chest X-ray will show the position of the pacemaker. It will show the leads, and some of them can also show you the type through their radiopaque codes. Okay. So X-ray can show that. So this is look like this is an ICD. You can actually see the thick wire which delivers shock. Okay, and you can actually see the two leads coming in. Okay. So X-rays are actually a useful part for that. This is a NASP or the BPEG pacemaker codes, and it talks about the first letter is for pacing chamber, second for sensing chamber, third is a response, fourth is a programmability, and fifth one is anti-tachycardia function. O is none, A is for atrium, I is for inhibited, P for programmable, P for pacing as well. V is for ventricle, T for trigger, D for dual. M is for multi-programmable, C is for communicating, R is for rate modulation, S is for shock, and D is for dual, that is for pacing and shock. So patients can present with various kind of pacemaker units. So for part of anesthesia, we know that if you use dexamethasone, it causes fasciculation. And sometimes this fasciculation can be misinterpreted as cardiac impulses. And this could lead to inhibition of pacemaker output, okay, depending on the type of pacemaker. The other worry is obviously is a surgical diathermy. I talked about it last time. And they can interfere again with the sensing unit. And the other thing is if the energy passes through the pacing unit can destroy the unit, or it can heat up the wire and cause damage to the sensing part of the the wires. So that's the main worry about anesthesia part. Then the next question is that, oh, can we use magnet externally paced? Well, it all depends. And if it is simple programmable demand unit, putting a the magnet can bypass the sensing unit, and it can actually then reprogram this to a fixed rate or asynchronous rate. But if it is a multi-programmable unit or multi-programmable pacemaker, it may be reprogrammed by diathermy, and this instability can be enhanced by external magnet. So this may not be the best way. And very rarely, I mean, this is VO or types of pacemakers are very rarely used. These are usually not affected by external magnets. So you actually have to need, the magnets are normally used to find the battery life for the pacemakers. But certain pacemaker units, if you place them on the the unit itself, pacemaker unit, they can turn it into the fixed mode, and these are very useful in the emergency situations. But this is not an emergency case. This is an elective or semi-elective case. So there is a time to find out what kind of pacemaker this patient had, and accordingly, you can then decide what do you need to do with it. If the patient has got an ICD, then it needs to be switched off before the patient gets to the theater. And then again, once it comes out, then you can actually get it switched on or reprogrammed. And when it's switched on or off, that time the pacing unit can be turned to a fixed mode. So the investigation, we will look at to a lead ECG, we'll look at the rhythm, we'll look at the evidence of electrical capture. Chest X-ray, like I have said, we will look at the position of the pacing box, integrity of leads. We'll look at whether there are any fractures. We can also find out from where the pacing wires have been placed into. Okay. And some pacemakers, like I said, you can actually look at what type it is, but not all pacemakers, you can do that. It's important to actually make sure the electrolytes are normal, because hypokalemia can cause abnormalities in capture. Okay, so it can lead to loss of capture. I'll talk about reprogramming, and this is important, especially if they have ICD or if patients have the antitachycardia function. Again, that's the implantable defibrillator with the ICD. These are very, very important. Intraoperatively, the best thing to do is to actually use bipolar diathermy, use the minimum energies, and use in short bursts. And the plate or the indifferent electrode should be sighted as far as possible from the pacemaker unit, and make sure the current doesn't pass through the basic unit or the wires. And if you're looking at the defibrillation, so if you're worried that something might go wrong, place a pad anteriorly on the chest, and so this anterior posterior placement is useful. Again, you avoid the energy passing through the unit or through the wires. After the surgery, it's important that the patient is in the monitored area. It goes into the recovery and the HDU. And they would need a recheck of the function would be required. Now, the new guidelines actually say that if the patient actually has got a simple pacemaker, it has been checked within the last 3 to 6 months, and the surgery is on the peripheral area where there's not going to be any current passing through the unit, then you don't need to actually have anything. You don't need to do anything at all. And intraoperatively, if there have been no changes in the rhythm, there have been no problems, and again, you don't need a post-op check. So these are the latest units, guidelines about the pacemakers. The fourth question is on ITU. It is about the physical principles underlying hemofiltration. List the indications, contraindication, and complication of hemofiltration. So the basic principle of hemofiltration is about the delta pressure. So delta pressure is the inflow pressure plus the outflow pressure, the mean of that minus the filtration pressure. So that is your transmembrane pressure. Thank you. So that's the basics of the pressure. Okay. So there are two things that we need to know is about. One is the diffusion, another is the convection. So when movement of solute occurs along the concentration gradient across the membrane, what will happen is that the solute will move till there is an equal gradient across the membrane. So that is what diffusion is. So this is the concentration. But when water driven by hydrostatic or osmotic pressure across the semipermeable membrane, it will carry the solute along with it as well. Okay. So this is called a solvent drag occurs. So not only the water passes through the membrane, and it also takes along the solutes along with it. Okay. So you are actually getting better clearance of the solutes. So if you look at the graph of the molecular weight of the particles are on the x-axis, the clearance on the y-axis. So when if you look at the diffusion clearance, it is slower or less efficient than the convective clearance. So like I was saying, the transmembrane pressure is equal to the hydrostatic pressure minus the oncotic pressure. So the larger molecules cannot pass through the membrane, like your albumin and large proteins, they can't. So they actually have the oncotic pressure. That's a transmembrane pressure. That will actually hold the fluid within the compartment, but the smaller particles will. Okay. So what is filtered out across the membrane, and that is determined by the type of membrane. It determined by the hematocrit, and the serum albumin. These are the ones which will determine the oncotic pressure. It will depend on type of vascular access, so are doing veno-venous or arteriovenous. Arteriovenous is not used much now. And mean artery pressure only depends on if it's arteriovenous, but otherwise, if it's veno-venous, then we actually use a pump. And it also depends on whether you're using a pump or suction at the ultrafiltrate part as well. So this is a basic of all kinds of the renal therapy. So you have the hemofiltration, you have the blood pump, which pumps the blood through the hemofiltrate. You can have pump for dialysate, you can have pump for effluent. And we can actually use pump for pre-dilution and post-dilution. And we can also add we have to add anticoagulants, obviously, so that the filters don't clog. So particles which are less than 20,000 Daltons are filtered passively. So these are sodium, potassium, bicarb, ammonia, glucose. Some of the soluble endogenous substances like myoglobin, insulin, interleukins. Certain exogenous substances circulate in plasma, like your medication like vancomycin, heparin, and toxins like endotoxins and pesticides. Solids of less than 100 Daltons are, urea, creatinine, uric acid, sodium, potassium, ionized calcium, and drugs that are not bound to plasma protein. These are easily filtered out. So all the continuous veno-venous hemofilters are impermeable to albumin and solids which are more than 50,000 Daltons. Okay. So it is only particles which are actually less than 20,000 Daltons which are seen. So if you look at the creatinine clearance, it depends on the type of fibers we have said. So most of us actually use hollow fibers, and this will lead to creatinine clearance of around 10 ml per minute. And clearance as is defined as the amount of plasma cleared of the substance. Okay, so it's not the amount of the solute; it's the amount of the plasma which is cleared of the cleared of the substance. So it's 10 ml per minute for hollow fibers, is 20 ml per minute for parallel plate. And this is without a use of dialysate, but if you use dialysate along, with hemofiltration, then this clearance can be increased to 25 ml per minute. So it can be quite high here. And it's also important what material the hemofilters are made of. They should be biocompatible. These are normally made of polysulfone or polyacrylonitrile or polyamides. And these substances do not cause activation of the complement and do not cause leukopenia. Leukopenia and complement activation can be seen with some of the hemodialysis filters. So this is the basic of the hemofiltration. So we have the extracorporeal pump because this is veno-venous filtration, hemofiltration. Draw blood, it passes through the filter, and then you replace the fluid. So pre-replacement fluid is normally not done. And again, we do not normally use dialysate along with the hemofiltration, but it can be used. It can be used if you want to improve the clearance. Then you can. Continuous arteriovenous hemofiltration, and this one, it uses the mean artery pressure. So one port is in the arterial line, other is the venous. So return occurs through the venous. So this will depend on the mean arterial pressure of the patient. And continuous venous filtration, so you can actually have replacement fluid, and like I was explaining before, when there is convection, then you can actually increase the amount of the ultrafiltrate And this can go as high as 35 liters per day or 20 to 25 ml per kg per hour. Coming to question number 5 is on cardiopulmonary bypass in adults. So what are the principles of cardiopulmonary bypass and what are the main complications of this technique? So basically, a cardiopulmonary bypass replaces the function of your circulation, and this is done by ensuring that there is organ perfusion. So perfusion pressure is important, and there is oxygenation. Okay, so oxygen need to be added, and carbon dioxide need to be removed because you're bypassing the cardiac as well as the pulmonary circulation. So for this, we need to know what are the components of the cardiopulmonary bypass. We'll need a venous line. So this comes from the vena cava. And whatever is collected from this line is drained into a reservoir where the oxygenation occurs and carbon dioxide is removed. So there can be two types of oxygenator. We have bubble oxygenator. So oxygen is bubbled through the perfusate. Okay, so these are cheaper, but then they require deforming because as you bubble through the blood, it starts forming, and then this can cause air embolism. At the same time, it can also damage the red blood components. So bubble oxygenators were used in children, but mostly we use membrane oxygenators, and this is the gas exchange takes place across the semi-mobile membrane. So there is less chances of embolization and damage to the RBCs. Then once the blood is oxygenated, it needs to be returned back, and this is through the arterial line, and this is done in the ascending aorta via pump. And these pumps can be pulse style or non-pulse style. And there are obviously lots of pumps. The pumps to pump in the cold cardioplegia, which will contain potassium to keep the heart in a arrested position. And they also contain energy substrate for metabolism. We have a pump for the ventricular drain to vent the heart. Okay, because there may be some amount of aortic regurgitation if there's no proper aortic clamp. And there can also be blood collecting through the bronchial and Thebesian vein, which can lead to over distension of the left ventricle. And this can cause critical ischemia. And this can lead to post-bypass dysfunction. So it's important to actually have a good ventricular drain as well. There are filters, 27 micron filters on both sides of the circulation. This is to remove air and any microemboli. And these can cause reduction in platelets. There are heat exchanges along with the oxygenators. This is important to maintain the temperature. And the hypothermia reduces oxygen demand by 6 to 9% per degree fall in core temperature. So this is important. So patients are actually kept cold. And towards the end, we need to also warm them up. So it's for both cooling as well as warming. So the other thing which is important is priming. So what do you prime the whole system with? There's a large volume, nearly 1.5 to 2.5 liters. So the priming is usually done with crystalloids or colloid or crystalloid combination. In adults, mostly just crystalloids. And because of this priming, there can be acute hemodilation, which will happen when the bypass is established. But sometimes if the patient has low hemoglobin, then blood can be used to maintain a hematocrit of 20 to 25%. Blood is normally used in pediatric cardiac surgeries. The other important thing is anticoagulation is very crucial because you don't want the system to coagulate and a coagulation occur within the system and then everything, that'll be lethal. Okay. Because the surface, the tubing are all synthetic surface and this can actually lead to activation of coagulation and this can lead to thrombosis within the system and within the oxygenator. And that's why ACT monitoring is a very important part of cardiopulmonary bypass. So total heparinization is done. So ACT monitoring is done to maintain the coagulation, but also for reversing the heparinization. So when you actually reverse the heparin. That's also important. So we can actually see in this diagram, they can see the vena cava, superior inferior vena cava that is collected. You can actually see the ventricular drains. You can see the pumps, the filters, oxygenator, the blood being returned back to the ascending aorta. Or you can draw a simple diagram. So you got the heart, you collect the blood in the heart into the reservoir, and you also collect from the left ventricle with a filter. It goes through the oxygenator and heat exchanger, passes through the filter and bubble catcher, and pumped back into the ascending aorta. Okay, there's extra filter as well, so or the pump as well to collect the blood from the left side. Okay. So that's again in a simple diagram, which can be used in the exams. I think that um, you can describe each component, but trying to actually tell why a diagram, it makes so much of sense and makes it easier for examiner to give a good marks. So complications can be on the circuit side. On the venous side, there could be low return, and this can be because there is bleeding happening, there's obstruction, there's airlock, or there's aortic dissection. On the arterial side, it could be the cannula may kink, and there could be block or failure to deliver adequate flow. If there is inadequate left ventricular venting, in that case, there can be cardiac distension. There can be failure of oxygenation and removal of carbon dioxide. The pump, if the aortic cannula is in the wrong plane, that can cause aortic dissection. And as I mentioned, it's important to maintain coagulation, so maintain ACT. And so if coagulation is inadequate, then it's can lead to problems. And the reversal with protamine is again done based on ACT. But protamine itself has its own problems, and so there can be reaction to protamine, which can lead to anaphylactoid reaction, histamine release, hypertension, pulmonary hypertension. And there is chances of embolization because of the oxygenator air or air being sucked in, silicon from the part of the tubing, fat, embolization, platelet aggregation. These can actually happen. Then there can be complication related to perfusion. So hypothermia is maintained, like I said, and now the people tend to actually go for normothermic or not go for very low temperatures. But when very low temperatures are there, then there can be coagulopathy, hyperglycemia. There is slowing of drug metabolism, and the priming is required initially, so they can be overload because of fluids. Coagulopathy is possible. This can happen because of the complement activation, but it can also happen because of the decrease in the platelet numbers and the depletion of factor 5 and 8. And this is seen with, when the cardiopulmonary bypass is more than 2 hours. Then there can be myocardial stunning after cardioplegia, and that's why it's important to have cold cardioplegia. Complement activation can lead to post-perfusion lung, so this is ARDS kind of picture. Renal function is known, dysfunction is known as the bypass decreases renal blood flow and glomerular filtration rate by almost 30%. So it worsens as with the duration of the cardiopulmonary bypass. There can be problems with the central nervous system because embolization or hypoperfusion leading to potential ischemia of the brain. But embolization of the air, thrombus, debris, silicon can also cause subtle kind of post-bypass deficits. Gastrointestinal system, there can be hypoperfusion of this splanchnic bed, and this can lead to critical gut ischemia, pancreatic ischemia, the liver dysfunction. And this is not uncommon. Again, it's been in a patient requiring laparotomy in the middle of the night because the lactates refuse to actually come down and they open and you see the blood cut. Last question of the day is on anatomy. So this is describe the anatomy of the caudal or sacroepidural space and discuss the indications for this caudal epidural block. So anatomy part, caudal epidural space, this is a cavity which is triangular in cross section, and it is running along the length of the sacrum. Superiorly, we have the lumbar vertebral canal. Inferiorly, it sacral hiatus. Anteriorly, we have the vertebral bodies. Posteriorly, we have the laminae. And laterally, we have the anterior and posterior sacral foramina. Okay. So that's the caudal space. What does the caudal space contain? It contains the dural sac. There is filum terminale. There are sacral nerve roots, coccygeal nerve roots. There are venous plexus. There's fatty tissues. The fibrous strands or the connective tissue. So these are the contents of the caudal space. So wherever there are nerves, there are blood vessels. Okay, there is fatty tissue. So nothing special about this. Okay. So we can also draw simple diagrams. Okay, so like a triangle, and that's called. Then you can draw this sacral foramina, and then you got the coccyx. You got the sacrum with the posterior superior spine. The triangle is the caudal space, and above is the your lumbar. Okay. So that's the sacral hiatus there. Okay. So patient is normally lying on the side, but it can be also be done prone. You feel for the caudal space. You feel for the corner. The posterior iliac spine and the sacral hiatus, they form an isosceles triangle. You introduce the needle at around 45 degrees, pierce the sacrococcygeal membrane. You feel a give through, you feel a pop through that. And once you get that, then you have to reduce the angle to move the needle in, and then inject local anesthetic after a negative aspiration. There are lots of anatomical variations in this area. In the elderly, the sacrococcygeal membrane might be calcified, and sometimes it's difficult to enter the space. So you have to remember that. The volume of the sacral, the caudal space is around 25 to 30 mLs in females and almost up to 30 to 35 mLs in males. So if you don't use that volume, so minimum volume in females should be around 25 mLs, and in males around 30 to 35 mLs. So if you don't use that volume, you're not going to get a good block with caudal anesthesia. So indications is commonly used in pediatrics. In pediatrics, there is formula for how much amount of local anesthetic you can use. It's 0.25%, or depending on the volume, you can actually get the level from your inguinal area till the umbilicus, and even you can reach the thorax. Okay. So in pediatrics, it's technically simple, it's reliable, effective. It's used for circumcision, hernia repair. There's a common indication, but it's been used for others as well. So it has been used in, like I said, up to abdominal surgeries. The larger the volume you use, the higher the level you can actually get. People can have done even put catheters from the caudal space up to the thoracic level in pediatrics. In adults, can be used for perineal operation. I was explaining anatomy is not easy, but it's been used for hemorrhoids and other perianal procedures, and is usually used as single shot combined with GA in the adults. It can be used in obstetrics for forceps delivery. It can be used for pain relief after episiotomy. Frontinus caudal for pain relief during labor can be used, especially in the last stage when you see patients having a lot of pressure. Can be combined for the lower part of this surgery on the lower limb, but rarely used because you only get some parts of the sacral nerves. You don't actually get complete. So it has to be combined with other blocks. Transurethral operations, this is a good indication, and it can be used, and pain clinics is commonly used as a therapeutic indications for that for pain clinics. So it can be used for certain pain syndromes. Okay. So with this, we finish today's session, and we'll see you later next week. And I will also tell you the topics I will cover in the next session. Okay, see you.